computer. And all right, we're going. All right, so let me go ahead and share my screen, and then we'll start there. Just kind of clear some stuff up. Okay, lost where I was. Okay. So you should be able to see my screen here, which basically says male repro cell reg. And I'm trying to, there we go. All right, so here we'll start with testicular cancer. I found that had the least amount of information. So I wanted to make sure that we kind of had an idea of where we were with that. Okay. So for testicular cancer, this is the age range that it's primarily more common in, and the average time or average year that a male would be potentially diagnosed is going to be when they're 33 years of age. It is considered to be highly treatable and curable, about 90%, regardless of the stage. So there's several ways that it's classified. So it's either going to originate from the testes or it's going to originate from the stroma. So they consider if it's from the testes, that's going to be the germinal. So 90% of those will come from there. And then the remaining would come from the non-germinal. However, metastasizes early from the testes to the lymph nodes. And where it metastasizes to is going to be the retroperitoneum. It'll go there first, and then it's going to go to the lungs. So if we're talking about the retroperitoneum, what structures are in that area that where the patient may have some issues? Let's leave it at that. If it's in the retroperitoneal area. Okay. Kidneys, liver, spleen. Okay. Usually retro is more lower, so it's not going to be higher up. It won't be the higher organs. It'd be more like the hip area, those types of things. Once it gets into the lymph system, though, it's free to go, multiple places. The main place that a patient will have metastasis to is going to be to the lungs. So it'll go from the testes into the lymph system and then into the lungs. So when we look at signs and symptoms, just think about that retroperitoneum. Then it's going to make a little bit more sense. So there's, too far. So there's two types of classification. So we did say they're either going to originate from the germinal area, from the stromal area. If it's from the germinal area, then it's looking more at the sperm-producing cells, which would be the seminomas. And so that's going to come from the testes. About 50% of the tumors happen there. But this is like a more localized tumor. Therefore, we have the blood-brain barrier. There is a testicular barrier as well that kind of makes it made treating testicular cancer a little bit difficult because of the fact that it was hard to break that barrier. So the seminomas, those grow quickly, and usually you'll start seeing it in folks that are in their 20s. So how these tumor cells are in the testes, they're going to be kind of mixed with at least two different tumor types, which was another reason why it was kind of difficult to treat testicular cancer. From the non-germinal side, this is more from the hormonal producing tissues or our stroma of the testes. So this is going to be the Leydig cells or the Sertoli cells. Those are the two main types. But this particular one infrequently leaves the testes. So if it's in the testes, then that's usually where it stays. It doesn't metastasize outside of that. Risk factors. If they have cryptorchidism, which is basically the testes do not descend, and that would actually be discovered much earlier on in life. So remember that Tanner's model, stage 1, 2, 3, 4, 5. And you probably said, why do we need to know that? This is why you need to know it. So that way you understand that by this time, the testes should be at this location. And if it isn't, then we're going to potentially have an issue here. Family history of testicular cancer, cancer of one testes versus another. And, you know, sorry, white guys, you're 5% greater chance of developing testicular cancer. And these folks are not usually overweight. Most of them are usually athletic. And by the time they find it, it has already metastasized to the lungs. And what do you think the biggest reason why the identification time was so delayed? And that would be by the client or by the patient, not the physician. Or actually, you could chalk it up to both. Okay, scared, and failure to perform the testicular self-examination. So most guys don't want to fill up on their testes. They're just like, okay, this is weird. So they don't check it. You know, they just figure, hey, if they hang in there, we should be good. Sperm's coming out, we're good. We don't have anything dripping out, we're good. So that's another reason why they had, by the time it was found, it was at a higher or an advanced level. The onset is gradual, so it's not a rapid onset. Usually there's a lump or a mass on the testicle, and it's painless, so it's not a painful enlargement. So usually they feel like their scrotum feels much heavier, or it's heavy in the inguinal area or in the lower abdomen. They may complain of back pain, abdominal pain, weight loss, and usually if it's metastasized, then they're going to actually feel pretty weak. So the most significant diagnostic finding is going to be that painless enlargement of the testes. So self-exams, and this is controversial because it creates a lot of high anxiety, but they have not necessarily been Johnny on the spot in identifying cancer from these testicular self-examinations. But even if you're looking and something looks kind of, there's like an additional bump to it, then most people will know, okay, this isn't normal. Here are lab values. So lab values and diagnostics. So the HCG for women, that's usually, we test to see if we're pregnant or not. Guys can pee on this, and if it's positive, then they more than likely have testicular cancer. Also alpha fetoprotein, that's another one that can also be used. They can do also blood for this. And then our lactate dehydrogenase, that actually is elevated in several areas. So you can't say isolated by itself that the LDH would be a significant marker. Does that make sense? Because in the skeletal system and the cardiac system, your LDH goes up as well. So that this would require further evaluation. Blood tumor marker levels, which is what we talked about right above. So it can diagnose testicular cancer. It can also give them information about staging. And then they also use it as their follow-up. So they're going to monitor these levels. They're going to, do ultrasounds to see what's going on with the testes and how they're responding to treatment. So the other diagnostic tool would be an ultrasound, or they can do a CT of the abdomen and the pelvis. So this kind of gives them what's this extent of the disease. So how bad is it, how bad that particular cancer is. Chest x-ray, and that's if it metastasizes to the lungs, and then tissue biopsy. So this is the only definitive method. So all of the other ones are pretty much suggestive. However, the best way is to actually do a biopsy, get the tissue cell type, and they're going to need that anyway, depending on the types of treatment they're going to utilize for it, to determine whether the cancer is present or not. So usually they don't biopsy before the surgery. So usually sometimes, like if a woman finds a nodule in her breast, then she'll actually have a biopsy. For guys in relation to testicular cancer, they don't do that at a separate time. So they do it once they're in surgery to minimize the risk of spreading the cancer or the cancer spreading in other places. So just kind of FYI on that. Highly responsive to treatment. So TX here doesn't mean Texas. I do have some abbreviations. They're a little bit of Hudsonisms, but I'll tell you as we go through. Does have a 5-year survival rate of 95%. And we're trying to get rid of the cancer to get, so that the patient is in remission. So usually the treatment's going to be based on the cell type, which is the reason why that biopsy is going to be imperative to do. And then what's the extent of the cancer? Has it metastasized in other places? So the orchiectomy, which is another word for castration, where the testes are removed, this testicular removal may be done with or without lymph node dissection as well from the retroperitoneal space. So complications post an orchiectomy would be having ejaculatory dysfunction. Usually libido and climax are usually unimpaired, so that's usually A-okay. But before you actually do take the testes, there's some consideration that maybe they want to freeze their sperm. So they may do cryopreservation of the sperm. So that way, if they choose to have children, they can at least do in vitro fertilization. All right, so looking at the seminomas, they're more responsive to radiation therapy. And usually radiation therapy as a monotherapy achieves good results for the majority of testicular cancer. From the lymph, they will take this, or they will actually radiate from the length of the diaphragm to the iliac region, just to make sure that whole area is in that retroperitoneal space is getting rid of the cancer cells. Chemotherapy is usually done for stages 2 and above. So they'll usually use the cisplatin-based type chemotherapy to help achieve the patient to remission. So any questions about the prostate? I mean, the testicular, does that kind of clear that up? Okay. So in there, it lists, what you need to look for, what you need to treat it for. And then, think about your surgery. What would be the things you want to tell the patient, about those complications? They may have some ejaculatory dysfunction, but their climax and their libido should still be the same. And then things about, preserving sperm. So that conversation needs to happen before, they go in to do this particular surgery. All right, so let's look at the prostate part. From the prostate area, again, the most common form of cancer for men is going to be prostate. And these survival rates look pretty decent, all the way up until you get to certain ethnic groups. So usually 66% of these cancers are displayed in folks 65 and older. So if they have a familial disposition, so in that first generation, father, brother, son, then that can predispose them to developing prostate cancer. Diets high in red meat or high-fat dairy products can also predispose them for prostate cancer. African American men have the highest incidence of prostate cancer, and some of that is because of, healthcare disparity, lack of access to healthcare, lack of insurance to to go to a physician. So by the time they catch it, it's pretty much, at a higher or an advanced stage. Some cultural constraints, because you have to do that digital rectal exam, so people feel a certain kind of way about those DREs. Northwestern European men, and then increasing age. So as they get older, the risk of developing prostate cancer increases. Usually during the early stages, they're asymptomatic. So if the mass is large, then it will actually encroach on the bladder neck. So the patient may see signs and symptoms of urinary obstruction, painful urination, urinary frequency, force of urinary stream. So they're actually forcing the urine out. Or if it's involving the urethra or the bladder is involved, then it's going to have, they may have bloody urine or hematuria. It can metastasize to the bone and the lymph, so this is kind of commonplace of where it travels. So backache, perineal or rectal discomfort, weight loss, anemia, nausea, and then if they're peeing less than 400 milliliters per day, that's less than a half a liter, then that may also be a sign that this may be prostate driven. And don't forget about benign prostatic hypertrophy, right? So they usually start with that where they feel like they got to go, and then when they get there, it's like hard for the stream to actually start. So it takes a little bit before the urine flows out. Screenings, there's some guidelines on when they should be screened. Between 55 and 69, they should go every 2 to 4 years. Prior to that, it's not necessarily recommended unless they're in that high risk group. So that African American male should definitely be getting it done. Usually that digital rectal exam, this is what the DRE is, not necessarily Dr. Dre, but just saying. Blood PSA levels should be checked. And usually the higher the level, the bigger the mass, but it doesn't necessarily mean that the mass is malignant. So it just means that, you know, it's a bigger mass than it's a growing mass. They use something called a Gleason score from biopsy tissue. And so that's how they grade, you know, how significant the cancer may be or the tumor may be. And, you know, it could be between 2 and 10 as a reading, but usually for the Gleason score, they're using the 6 to 10 rating. And it's, you know, you can look up the particulars in your book, but if they have a score less than 6, then they're considered low risk, but they do monitor the patient closely if the level is 5, because the likelihood of reoccurrence or those numbers going up is high. It's not necessarily reoccurrence, but the likelihood of them developing prostate cancer is increased. So 7 is an intermediate risk, and then anything above 7 is considered high risk. My understanding is the Gleason score is actually only used for prostate cancer, but I can verify that for you by the end of the Zoom session. Someone asked the question if the Gleason score was used in other cancers. Primarily prostate. So it's specific for that. All right. How do you get a histological exam? Ooh. Biopsy. So they will look at the tissue, and that's their best confirmation. That's how they also get that Gleason score. Best confirmation of, you know, whether they have how significant the mass is. They can also do a transrectal ultrasound. That's what a TRUS is. So that also helps give them information if there's a mass there as well. And they can get the sizing of it. Why would we get a bone scan? For metastasis, if it goes to the bone, because we did say that was one of the places. CT pelvis will tell you if it's metastasized to the pelvic lymph nodes. You can also they're doing the MRI ultrasound biopsy fusion. And so that's for, excuse me, for folks that have a negative ultrasound, but their PSA levels are increasing. Okay. Radical prostatectomy. What is a radical prostatectomy or a prostatectomy? What are they taking when they do a radical prostatectomy besides the prostate?
Prostate and lymph nodes.
True. The prostate's gone. The seminal vessels are gone. And usually they take the fat, the nerves, and lymph nodes and blood vessels around that prostate. So it's more than just the prostate. They're going to take the seminal vesicles. They may also take the fat, the nerves, the lymphs, and the blood vessels along with it. So that would be it's kind of like a radical mastectomy where they take them both off and take other additional structures with it. Usually first line of treatment is going to be with this radical prostatectomy. That's the first line of treatment. But the biggest complication is erectile dysfunction. So here's one of the Hudsonisms, instead of spelling function all the way out, I just shortened it for myself. Other things they can do in the early stages is a radiation therapy. And there's two types. There's teletherapy and then there's brachytherapy. And they're using a lot more brachytherapy to help with treatment of prostate cancer with good success, by the way. The best results is if they use a combination therapy between radiation and hormonal therapy. So as we move forward, you'll see what I'm talking about. So teletherapy it's an external process for which they are going to do an external beam radiation. Takes about 6 to 7 weeks. So they'll have 6 to 7 weeks of radiation therapy. They're doing it 5 days a week. So that's a lot of singeing, right? They're going to try to preserve if it's only in one testis. So they're going to shield the other one so they don't mess that one up. And they're going to set the dose to that target or to the target tissue, but to the adjacent tissue, like the seminal vesicles and fat and all that, they'll have a reduced dose so it doesn't cause unnecessary damage. So they're usually pretty accurate within 1 to 3 millimeters, which is, that's pretty dang good. When you're looking at the brachytherapy, so here, this is an internal procedure. And what they do is they insert these radioactive seeds into the prostate directly. And it's a same-day procedure or one-day procedure. The patient goes home. The only concern is that they need to make sure they're not around anyone that's pregnant or infants that's less than or equal to 2 months of age. So here with this particular therapy, then the radioactive seeds would just go in and radioactively, radioactively treat the tumor or the cancer at that time to eliminate it. So I do know a gentleman who actually had this brachytherapy done, African-American guy, by the way, with good results. So that was good to hear. All right. So side effects from the radiation therapy is going to be inflammation to the rectal, bowel, or bladder because of the location of the prostate to these structures. And over time, they're going to begin to experience erectile dysfunction. Hormonal therapy. Usually this is used with advanced prostate cancer disease, that disease process when it's at an advanced level. And they're going to do is suppress the androgenic stimuli to the prostate, and they do it by 2 different methodologies. They're going to can decrease the level of circulating plasma testosterone, or they can interrupt the conversion to or binding of the DHT. So what is DHT, by the way? Dihydrotestosterone. So the endogenous androgen, sex, steroid, and hormone. So it's actually included. It's actually in the prostate gland. It's in several areas: seminal vesicles, the epididymis, liver, and brain. And what this does, it will now cause the epithelium to atrophy. Okay, what do we mean by atrophy? Makes it smaller. Okay. So the other thing that they can do is the orchiectomy. It decreases the mass. Okay. Next one. Okay. So they can actually use the orchiectomy. So that's the castration, or they can also, and they're speaking about the epithelial atrophy, the atrophy of the epithelium, the prostate epithelium. So they can give medications. So non-steroidal anti-androgen bicalutamide, bacalutamide. Got ahead of myself. Or the luteinizing hormone releasing hormone agonist, which is the leuprolide or the goserelin. So those are your non-steroidal anti-androgen meds. And then we have anti-androgen agents like flutamide that can also be utilized to treat. And this is hormonal therapy. That's all we're talking about. And with this therapy, this should actually cause that to atrophy, to die, to get smaller, and then they can eliminate it. The other thing with the luteinizing hormone releasing hormone agonist, it suppresses the testicular androgen. And if they use the anti-androgen agents, then that will also cause suppression of the adrenal androgen. So, they may add that in addition to the brachytherapy or to the teletherapy. There is a second line medical treatment that could be done, and this is for hormone refractory cancer of the prostate. And this is kind of controversial, but they may use ketoconazole to help to do the same thing, to decrease the testosterone by decreasing the testicular and endocrine production of the androgen. So they're not quite on board with that second line therapy, but it's an option. All right, so we have cryosurgery of the prostate. And if they do cryosurgery, that's used to ablate the prostate cancer in patients who can't tolerate surgery, and in those who have recurrent prostate cancer. So here they'll put in some probes into the prostate directly under ultrasound guidance, and they'll freeze the tissue directly. So that's how they do the cryosurgery of the prostate. What is a TURP? What is a TURP? So your book should give you, there's like several different surgeries that can be done. TURP is one, TULIP is another. We talked a little bit about a prostatectomy, which it'll actually take it out. So what is a TURP? So yes, it's a transurethral resection of the prostate where they do it under endoscopy. And so they will go through the urethra to the prostate so they can view the prostate directly. And the gland is then removed with small chips with an electrical cutting loop. So this procedure may be used for glands of varying sizes, and it is actually ideal for patients who have small glands and poor surgical risk. So that's one option. The other one is the transurethral incision of the prostate. So one is a resection, the other one is an incision. So with the incision, they usually do this when the prostate gland is small, so less than 30 grams, and it is an effective treatment for many cases, even to treat benign prostatic hypertrophy. So they pass it through the urethra, they make an incision in the prostate and the prostate capsule to reduce the prostate pressure on the urethra and to reduce the urethral constriction. So that's another option. Then they have the prostatectomy, so they can do a robotic method. So the laparoscopic one that gives you better visualization of the surgical site. And they have several approaches, and that's why I just put prostatectomy, because they could either do a suprapubic approach, they could do a perineal approach, or they can do a retropubic approach. So there's so many, there's several different approaches to that. What are some complications from surgery? What are some things that you want to tell your patient post-surgery? All right, so things we want to look at, you know, things we want to assess for after the surgery is our usuals: bleeding, hemorrhage, infection. They can develop a clot. So those are things we want to look at. Any type of fluid imbalances that may be present. So during that post-op time, comfort. So making sure we're keeping them comfortable. Make sure we talk about pain management. What is one of the more common electrolyte imbalance that we need to monitor for? Yep, stool softeners, rectal tubes. We don't want to have any of those. So what's the most common not fluid, but electrolyte imbalance? What would you think it would be? Don't pay that any mind. Sodium, so hyponatremia, so low sodium levels, okay? We want to monitor blood pressure. We want to check for confusion. We want to look for respiratory distress. So remember, it's a surgery, so we're looking for all those things that can complicate, you know, that are that can become life-threatening issues. Other things, especially if they can develop after a TURP, TURP. That's the biggest electrolyte imbalance we want to look for, is hyponatremia, so low sodium levels. Hemorrhage, because the prostate is a vascular organ. So that's usually an immediate danger post-operatively. So we need to monitor for tachycardia. And why tachycardia? Why do we want to monitor for tachycardia?
Can we talk on here?
Okay, it's an early sign of shock. So the first sign of shock, and this is compensated shock, so this is when the body is compensating, then it will increase the heart rate because the adrenal glands is going to release adrenaline. So that's the reason why the blood pressure goes up. So if we're bleeding out, then it's going to try and counteract that by raising the blood pressure, increasing the heart rate. However, the blood flow that you have in the rest of the body is going to leave the periphery and it's going to go to the core so that the heart, brain, lungs, and kidneys can continue to function. So it's going to feed those core organs that are essential for sustaining life. They may have hematuria, as we already said there, decreased levels of hemoglobin and hematocrit. So we want to get a CBC. We want to get a chem study. So check that hyponatremia. And then anticipate if we do have volume loss, what should we anticipate doing? What should we be prepping for?
Give fluid.
Give them some fluids or blood. So in that, if they've gone to surgery, they should already have a type and cross done. Why not a type and screen? What's the difference? What's the difference between a type and screen and a type and cross? A screen just tells you what your blood type is. A type and cross, basically, they're going to cross match it with your RH factor. So if you're O negative, O positive, or A negative, A positive, B positive, B negative. So this is going to be for the actual blood matching, if that makes sense. Okay. Other things we want to talk about, we talked about the erectile dysfunction. They may have decreased libido and fatigue. So these issues may now become a concern to the patient right after surgery or within weeks or months of rehabilitation. So we need to consider options to restore erectile function, like medications or surgically placing in implants and things of that nature. So we want to assess for the presence of sexual dysfunction. If they have any type of emotional challenges related to that, we want to make sure that we're addressing it. Self-care, so we need to talk about that. Making sure we give them appropriate instructions. They may do bladder irrigation, so that we got to talk about how to take care of that. Kegel exercises, someone had already typed on there. Somebody asked the question, you can't use a screen for transfusion. The answer to that is no. Anytime they're going to do a transfusion, they're going to do a type and cross match. So they want to make sure they're going to get the closest to it. That's why you have the universal donor is really O negative because of the RH factor. So that's why they need to know if they have a positive or negative factor. You just can't continue. Although O is let me just clarify. Although O is the universal donor, when you're talking about going to surgery, you want to give the patient the blood that's similar to what they already have, that's already in their body. So that's the reason why you want to make sure the RH factors match and that you're just not giving O neg. O neg is usually done in the ER, so that's not a mainstay process. It's only done that way in the emergency room under emergent situations. And even then, they're still going to send a type and cross match as a part of their trauma labs to make sure they get the right blood for that patient. Does that make sense? Did I answer your question? Okay. All right. So we did talk about Kegel exercises. Also, try to interrupt the urinary stream after starting the void. Wait a few seconds and then continue, so that'll also help to strengthen that area. How long do you think it'll take for that area to heal, for the prostatic fossa to heal? 2 weeks, 3 weeks, how long? Eight weeks. It actually takes about 6 to 8 weeks. So that's almost like a C-section, nearly. So yes, they should avoid activities that's going to, cause straining. They don't want to do any heavy lifting, as this may increase the venous pressure and produce a hematuria. How about long motor trips and strenuous exercise? Should they be doing a bunch of strenuous exercises and, taking real long trips? Nope, they should stay away from that, because that gives them the tendency to bleed. What about spicy foods, liquor, coffee? Should we be doing, having those types of drinks? Nope, we can't do those either, because that can also lead to bladder discomfort. Make sure they maintain their fluids, because we don't want them to get dehydrated, because if they're dehydrated, then this is going to increase their risk for clots to form and obstruct the flow of the urine. What things should they report to the PCP? So bleeding, passage of clots, decreased urinary stream, any urinary retention, signs and symptoms of infection. Okay. How about signs and symptoms of a UTI? Should they report that too? Absolutely. So, let's see. Any other questions? I think we covered the prostate relatively well. All right. So, what about looking at breast exams and breast cancer? So, tell me. I'm getting ready to flip on you. Tell me what you guys. Is bleeding normal for the first 24 hours after surgery? What do you guys think? Okay, we just need to monitor it, make sure it's not increasing. But when we're talking about when we're talking about hemorrhage, this is a whole different beast when we're talking about hemorrhage, because now we're losing a significant amount of blood, which is something we don't want to have. So we're still looking at how much blood loss they lost in surgery, and we're just making sure that we don't have any major issues. So speaking about that, before we go to the breast, what is PDE5 inhibitors? What is PDE5 inhibitors? Viagra, I love it. So it's an erectile dysfunction med. Make sure you know what the PDE part stands for. Also, so that way you can recognize it, because if you just only learn PDE, then they may not just put PDE. So they will give that after they do a prostatectomy, and they'll give it especially if they've preserved the neurovascular bundle, so to help improve erectile function. So just some things to kind of lay your eyeballs on, or know that you're going to have to address. So if you're not prepared, I won't say if you're not prepared, you're going to get hot real quick, meaning you're going to start sweating and panicking. They only give it if it's erectile dysfunction. And so if they know, Louina, if the patient has that potential for erectile dysfunction to diminish, then they may say, we won't start you now, but this may come up in the future. Does that make sense? Right. And the ED dysfunction med, and this is for the prostatectomy, if they have the prostatectomy done and they have preserved, so the question is, did they preserve the neurovascular bundle? So remember, when the prostatectomy, I told you they could take the fat, the nerves, the blood vessels, etc., if they did a radical one. So if they preserve it, then they can actually take this medicine. Does that make sense? So they need the neurovascular bundle to be there. What causes infertility? As I said several slides back, usually the first line treatment, let me just go back so that way I don't have to talk outside of my neck. So we talked about the brachytherapy. So usually the first standard line of treatment is surgery. That's what I talked about. Okay. But the complication of that is erectile dysfunction. So with that being said, then if they preserve the neurovascular bundle, then they can take erectile dysfunction meds. If they do a radical, they take everything. So say, the radical may not necessarily include the fat and the nerves, but you have to find out, did they take fat? Did they take nerve? Did they take lymph? What else did they take? That's going to determine whether or not ED medicine will be given. So, if there's a question to say, what other, post-operative processes or discussions or teaching would you do for a patient with a radical prostatectomy, then the erectile dysfunction medicine would be something you would potentially discuss, because of the fact we won't know until the surgery whether or not the neurovascular bundle was taken. So you just don't take them out the game, because you don't take them out the game. You have to wait. But that is a part of the treatment, modality, especially knowing that they will have erectile dysfunction afterwards. So I hope that kind of clears that piece up. No problem. All right, so let's move on to looking at breast cancer, because that's where we're getting ready to move to next anyway. And so I was asking you ladies and gentlemen to tell me what you know about breast cancer. And the only reason why is because I can feel myself getting ready to lose my voice. So this is the reason why I'll probably be asking you more questions, but I'll still be explaining, so don't freak out. Okay, 80% of cases are actually not related to family history. Okay, genetic factor BRCA1 and 2. Okay, and there were some other ones that I had, and I know some of you are not in my lecture class, but I did. Let me see if I can bring that up real quick. Bring up that PowerPoint. I'm going to stop sharing briefly. and bring up the other PowerPoint that I had. All right. And I'm going to share this with you guys. Okay, manifestations, hard immovable mass, okay, in the upper. Where is the most common place for breast cancer to develop when you're looking at the breast as a whole?
The upper right quadrant.
It's the upper right quadrant. So let me, before I do what I was about to do, let me pull up a picture real quick. So that way we can all be on the same page. So let me pull that up so that way. And this is also in your book. I want to try to get, I don't want anybody saying she was showing dirty pictures. All right, here we go. Well, I just want a picture. I don't want a video. All right, so let's just see. Let's see if we can just extrapolate this here. Tail of Spence, exactly. That's what I wanted to get to. And it is in the upper portion. But I think a lot of times people, when they look at the breast, they're only looking at just the front of it, not necessarily the whole, how the whole breast trails. I want to get a higher resolution photo. There we go. So I am going to put this in that PowerPoint that I was just talking about. All right, and then I'm going to share this screen. All right, so here's the tail of Spence. And let's wait on this to, there we go. Nope, I don't want any of that. Just show the slide. It'll let me do that. All right, so if you can see this here, Then this right here, the axillary tail, which is known as the tail of Spence, that's where usually most of those in this upper area where you start having issues, or that's where it's primarily discovered. So, for women, we talk about doing, breast examinations, right? Self-breast examinations. And some of that, even that's somewhat controversial as well, because it is very anxiety producing. All of these are not necessarily these bumps are not necessarily metastatic, right? So it could just be a fat tissue, so it's not necessarily cancerous. So some people do produce fatty nodules in their breasts. So it could just be a cyst, is what I'm basically saying, a simple cyst. Then you do have different types of breast cancer. So I just really wanted you to see this portion here. But you have different types of breast cancer. You could have a lobular carcinoma. You can have hyperplasia. You can have a malignancy. You can have something be in situ. So what is in situ?
Is that the more common one?
Not so much common, but it's more encapsulated. Does that make sense? So this is what let's see if it's the right one. So this is what I had from my class. And it just looked at the different tissue origins and things of that nature, if it was encapsulated, not encapsulated. And your book does a comparison of it. Oh, here it goes. Benign versus malignant. So, in situ just basically means it's encapsulated. So it just basically stays. It doesn't move. Does that make sense? So it stays in its original place, okay? So when we're looking at breast cancer for women, the two most significant risk factors for breast cancer are what? What do you think the two most significant risk factors for developing breast cancer are? %, it's because of gender and age. So usually the risk factor increases with age. And there are some other things, but the top two is being a woman, increasing age, and then we have if you inherited the genetic mutation for breast cancer, so the BRCA1 and or BRCA2, or other cancer susceptibility genes, family history, particularly with a first-degree relative that was diagnosed with breast cancer at an early age, so less than 50. History yourself of breast cancer, history of benign proliferative breast disease, especially those with atypia, high dose radiation therapy to the chest. So if you're being treated for Hodgkin's or non-Hodgkin's, then this will put you at risk for breast cancer. Hormonal factors, so getting your period before 12. So your menarche started earlier than 12. And when we have little girls having babies at 8, that's a problem. Late menopause, so after 55. Nulliparity, what's nulliparity? Yep.
Never been pregnant.
Never been pregnant, or no full-term pregnancy. So they've been pregnant, but they haven't gone full-term. Late age at first-term pregnancy, so gave birth after 30. or you got pregnant after 30, contraceptive use, hormonal replacement therapy that brings about breast cancer, so long-term use, history of ovarian or endometrial cancer, obesity, especially in those that are postmenopausal, not postpartum. My tequila lovers, my alcoholics, that's another risk factor. And actually, Jewish ethnicity related to BRCA1 or 2 mutation carrier risk. So they don't even have to have it, they just have to be a carrier. Okay? So that also increases those are all the risk factors related to breast cancer. So with screening and prevention, the big, self breast exams we talk about, we also have mammography. That's another one. And they just came out with a new one. I think now that it's not really new, but they're looking at breast imaging like MRI as a better methodology than the 3D mammography. So what are some protective factors that for, breast cancer, women with breast cancer? What will be some protective factors? So I could tell you smoking and obesity, that increases your risk for any cancer. Doesn't matter, it doesn't have to be breast. So if obesity is one of the signs, then maybe maintaining normal weight, particularly after menopause. So exercising, avoiding or limiting alcohol consumption. Women who breastfed for an extended period of time for a year or longer may have added, so I'm not saying does, but may have added some protective process. Women at high risk for breast cancer may be candidates for chemo prevention, and they may also opt to take tamoxifen or raloxifene to reduce their risk. Okay. So according to the American Cancer Society, annual screenings for mammography should begin at the age of 40 unless you have a history in your family or you have high risk. So they should do a clinical breast exam every 1 to 3 years, starting at 20, and then annually beginning at 40. So those are some numbers that I gave my class at one Northlake. So things to also prevent, risk factors is looking at genetics, doing long-term surveillance and things of that nature. We've already talked about the chemo prevention. Some people, if it's in their family, they just go ahead and do a bilateral total mastectomy, right? And another thing you would have to look at is if they took lymph nodes, because why would you need to ask about the surgery and if lymph nodes were involved if they do a total mastectomy?
You can't take blood pressure, right? Or do any kind of venous punctures?
Right. You can't take blood pressures in that arm. So that's the reason why you want to ask. You can develop lymphedema because now your lymph system has been compromised. So breast cancers can occur anywhere in the breast, but usually it is found in the upper outer quadrant where most of the breast tissue is located. So usually it's a non-tender lesion that tends to be fixed rather than movable. So it's like in a one spot. It can be hard with irregular borders. There's usually no other signs and symptoms. Sometimes people delay seeking treatment. They ignore symptomatology. And by the time they do go, it's at an advanced stage. So advanced stages, they will have skin dimpling or nipple retraction or skin ulceration. And that skin may have that orange peel appearance, which is known as poutarage. So it's a French term for basically orange peel skin. And that poo is actually spelled like P, I think it's like PEAU, Potorange. They can also do ultrasound to see as a screening or diagnostic adjunct to the mammography. They can do MRI, and that's get very detailed cross sections. For the Potorange, yes. Someone is that only in breast cancer? Are you asking for the Potorange? The answer to that is yes. They can do breast biopsy. So they'll do a needle aspiration, or they can do it under ultrasound. There's the stereotactic breast biopsy. So there's several different methodologies to do the breast biopsy, but just understand they'll probably get one done. Then we use the normal staging, the T, N, and M, right? And then prognosis varies, but the higher the stage, the worse or better the prognosis. It'll be worse, okay? So they can also do a lumpectomy. So take the lump out. Radical mastectomy, they could do that. And then some do or can do a breast conservation, so they can prep for reconstruction. And so there's some, I don't know if it's controversy, but I think if you have patients in that position, you want to give them every option and explain it in detail what it really is, or make sure the physician does that. So sometimes in that reconstruction format, they may opt to take their abdominal tissue to make breast, but they won't have a nipple. And sometimes it just really looks like they just slapped it up there. They really didn't, have any care in the world, like when they're putting in those silicone boobs or saline boobs. And then those folks are also at risk for lymphoma. So I don't know, I don't know if you know folks that have had breast augmentation, but that they do carry, especially the silicone breasts do carry a risk of the patients developing lymphomas, because you have that toxin very close to the lymph nodes. So yeah, and if they do have the lymph nodes taken out, so no blood pressures, no injections, no blood draws. Now, if they do bilateral, then it's not gonna really matter at that point, right? They should use sunscreen. They should use insect repellent. If they're gardening, they should wear gloves. Use a cooking mitt to take out hot items, but that seems pretty self-explanatory. Don't cut the cuticles. They should just push them back during manicures. No electric razors for shaving the armpit. Not lifting any objects between 5 and 10 pounds. So there's a lot of different things. No tight clothing, no tight jewelry, no elastic bands, no chemical hair removals for the skin, for the armpits. So there's a lot of different patient education, teaching things that need to be done. And we did talk about lymphedema, so that could be an issue. What else can you think of? Yep, no cutting the cuticles.
How come?
This is more about hand care at this particular point. I'm not sure of the exact rationale why, but your book says not to cut the cuticles.
Would it be for like risk of infection if they like cut the cuticle and then they take a little bit more and take the chunk of the meat?
It could be. It could be. And since you're taking out lymphs, that would be problematic. Oop. All right, what else? What else can you tell me? You got your labs that you would need to do for that specific cancer. Yep, it's for infection. I think that was Kathy. Yeah. Body image and coping, absolutely, absolutely. And they may need, you know, a psychologist, social worker, somebody to come talk to them. Because if they have to have their breasts removed or anything like that, that's going to be definitely a body image issue. Okay, so there's, and I'm not going to talk about the different reconstructions because that's going to be person dependent. But I do want to talk about treatment modalities. So let's look at radiation. They can do radiation therapy, and it can be external or internal that they can have. If they do outwards, so an external beam radiation, that's going to be about 6 weeks of radiation therapy after breast conservation surgery to allow the surgical site to heal. So they're going to start that 6 weeks after. So they won't start it immediately. If they need to get chemotherapy, if it's indicated, then radiation therapy usually begins after chemo is completed. Okay. So again, they're using high energy. Each treatment only lasts a couple of minutes, and generally it's given 5 days a week for about 5 to 7 weeks. Okay. The internal radiation therapy, which is the brachytherapy that we talked, kind of similar to the prostate cancer. Here they put in a radioactive substance sealed in needles or seeds or catheters or wires into the breast. And then it will go ahead and eradicate the tumor tissues. They do it, it's given twice a day over a 5-day period. So some patients get both internal and external. And the type of radiation and frequency is going to depend on the tumor stage, the classification, and location. So some of our things that we want to do is, you know, usually it's well tolerated, radiation is, but some of the acute side effects is redness, breast swelling, fatigue. They may end up with skin breakdown in that area. So they need to talk about them being tired because this is kind of a draining process. Usually the side effects will go away within a few weeks to a few months after the treatment's completed. So, but some self-care that they can do is, and this is only to the area being treated, not to the rest of the body. So they can use mild soap with minimal rubbing, no perfumey soaps, no perfume deodorants, no they can use like Lubriderm or Eucerin because they have hydrophilic lotions, which would be good. A non-drying antipyretic soap, so like Aveeno, to if they get itching. No tight clothes, no underwire brasiers, no extremes of temperatures or excessive temperatures, and no ultraviolet light, but making sure they do use sunscreen, at least 15 and higher. They have something that they have a neoadjuvant and they have an adjuvant therapy. So this is systemic treatment uses anti-cancer or anti-neoplastic drugs. So they get that either intravenously or orally. And it travels into the bloodstream, and it's designed to destroy the cancer cells that have escaped the breast and the axillary lymph nodes. So what is a neoadjuvant therapy? When do they do that? The neoadjuvant. What is that in conjunction with? When do we do neoadjuvant therapy? So that's usually done right before surgery. So this allows for the assessment of the tumor's response to the chemical agent, and then it's used to shrink the tumor before they actually do surgery. So this is chemotherapy. And then once this tumor is shrunk enough, then breast conservation surgery without the need for mastectomy can be done. Then they have an adjuvant therapy is administered after the surgery. So if it has neo in front, it's before. No neo, then it's done after. So then it is used to eradicate any residual cancer. So they have a couple options. Then we have the biologic therapy, which is the HER2 growth promoting protein. That's usually seen in about 15 to 30% of the breast cancers. And usually it results in faster growth and a higher reoccurrence rate than in tumors that do not overproduce. So they can use a monoclonal antibody that targets that particular protein and reduces the recurrence rate. Then we have hormone therapy, we have chemotherapy for patients as well. So hormone therapy will be your tamoxifen or your letrozole, which is an aromatase inhibitor, but that's another form of a hormonal therapy. Trastuzumab, which is a biological therapy. So we have options. What are some side effects of chemotherapy for your breast cancer patient besides nausea and vomiting? And those are significant because after a patient is getting chemotherapy, you know, they're going to have alopecia, so we got to worry about that. But we also need to clear it through the kidneys. So we need to make sure we don't end up with acute kidney injury. So they need to increase their fluid intake as soon as possible. Bone marrow suppression, their taste buds may change. They may end up with ulcerations in the mouth that are really painful. Stomatitis, yep. If they're still on their period, they may have amenorrhea, so absence of a menstrual period that could lead to sterility. So we need to make sure we tell them to, can they get hot flashes? Is that another side effect? Hot flashes?
Yes.
Yep, and that's especially with your hormonal therapy, your adjuvant hormonal therapy. So there's a lot of things like no caffeine, no spicy foods. You know, you may have some vaginal dryness and things of that nature. So we want to tell patients as soon as they're done with their chemotherapy, they usually send them home with some antiemetic on board, like that they received when they were receiving the chemo, but then they need to take it at home as well and look at giving them the optimal dosages to help minimize nausea and vomiting. Measures to reduce the mouth sores or stomatitis, biotine, that's a good one to help with that. That's over the counter too. But no spicy foods, no hot foods, no fried foods. Some may need the hematopoietic growth factors to minimize the effects of chemotherapy, like neutropenia and anemia. So if we're talking about neutropenia, what are we speaking about? Low white cell count? Which white cell?
Neutrophils?
It's the neutrophils. That's why it's neutropenia, because the neutrophils are low. What's normal? What's the normal range for neutrophils? $2,300 to 6,000 cells. So this will be cells. Oops, didn't mean to, I don't want to be yelling. Per millimeter cubed. So that's the range. If they are less than 500, oh my gosh. So the lower the number, do they have the higher the risk of infection or the lower the risk of infection?
Higher risk.
It's a higher risk. So the lower the number, if we start hitting that 400 mark, we need to be worried about sepsis and all of that. And potentially the person dying. So they may, literally tap out. So that's why it's imperative. So that CBC, chem studies, we want to be looking at that because we want to make sure they don't develop, tumor lysis syndrome? So they have a bunch of electrolyte imbalances, and you actually have an article. When would you put a patient on neutropenic risk? What do you guys think? Someone actually asked the question for that, and that's a very good question. When it's less than 1,500 or 1,000? Which one? Because you actually do have an article. Less than 1,000. If it's less than 500, I mean, you're past there's a lot of issues there. So if it's less than 1,000, then that they're on neutropenic precautions, okay? So the lower the number, the more increased risk they have of developing an infection. So we need to be very mindful of that. Not dead yet. I love it. So hopefully they're not dead at that time, but we can't have people in there with colds. If they think they may have something, they need to stay home. And if they have a fever, then we know they have an infectious process. So we need to prepare for blood and urine cultures and for them to be on antibiotics. But they need to, strict hand washing is imperative here. So we don't want to, tip the scale in the wrong direction. We're trying to help people not contribute to their demise. All right. Another problem they could have is anemia. So they can give them some granulocyte colony stimulating factors to boost their white cell count to help reduce neutropenic fever and infection, which would be what? What is that drug called? Neupogen? Okay. Now, what's the one to increase the red blood cells to help with anemia?
Epogen.
Erythropoietin? Yeah, erythropoietin. So just understand that they will get a boost of that before they leave as well. So chemo can have a lot of, negative side effects, self-esteem, sexuality, sense of well-being. So we need to just make sure that we have that open dialogue with our patients and get them to the appropriate support people and support groups ASAP, okay? Then we look at survivorship, because that was part of your, that was also in your reading. So looking at the quality of life as well. Breast cancer women have become some of the largest group of cancer survivors, but some of them do have recurrent breast cancer, or recurrent cancer may not necessarily be breast. That can happen. So we need to look at long-term effects. We need to learn about the long-term effects and intervene appropriately. So that way they can optimize their quality of life. So when we're talking about infections, it could be UTI, it could be lung, it could be pneumonia, it could be any infection. Okay. Anything else you can think of about breast cancer that you have a burning desire to learn?
Yes. What's on the test?
Say that again. I didn't hear you.
Yes. What's on the test? That's what I want to learn.
Everything.
Miss Hudson,
Yes.
my sister had breast cancer, and it seems like there was something about not going to the bathroom after her. With radiation.
With chemo, yeah.
Okay, with chemo. Okay.
Yep, that is true with the chemo. Yep, because that's a toxin.
Okay.
So yeah, you got to clean all that up first.
And is that there's like a special area in the hospital that takes care of that?
Usually housekeeping.
Okay.
And so if they're on that floor, they know exactly what material to use.
Okay. Okay.
And then if you're going home with it, then they'll tell you what to do.
Okay.
Okay. So I'm confused. Someone has in here, Miss Aaron talk about it in class. What do you mean? Oh, was I not supposed to know that?
I think she's talking about arm exercises.
Oh, someone said you can't ask that, and somebody said Miss Aaron talks about it in class.
Oh, I think that girl was responding to my question about I want to know what's on the test.
Oh, okay, got it.
She doesn't know my humor, I think.
I mean, so what are your struggles with the material? Because if you're trying to learn everything, so say for instance, if I decided today I'm going to study for 5 hours, and then for 5 hours, all I do is study everything from start to finish, then that's going to become super overwhelming. So the best thing to do is to go through your exemplars and look at, what does my syllabus say? So there's not a whole lot of information like on testicular cancer, which is the reason why I made sure that there was some homage done to it. People get breast cancer, people get lung cancer. They understand those very easily. It's usually that prostate or that testicular one that they don't quite understand. And is it a lot of information? I do agree with you. It is a lot of information, but I can't pare it down for you. I wish I could. Me paring it down for you may set you up for failure on NCLEX, which that I can't be a part of. So I will, do what I can to help you understand it better, so that way you are more successful. Because what I don't want to see happen is you get to a certain point where you're going to always be overwhelmed in nursing school. So let me just say that it's not going to be a time that you're not going to be overwhelmed. So if you're thinking that's going to happen, then I'm just going to tell you, However, you can minimize how overwhelmed you are by, number one, studying a little bit differently. So studying in smaller periods of time per day. So if you put in 4 hours per day for 5 days a week, pardon me, then you should start to develop a routine where you actually can understand what it is you need to know. But it's more than understanding. Then I would go back and do, sometimes your Prep U material has interactive case studies. So you just, when you go to your concepts and then you pick one of the exemplars, if it says interactive case study and there's a case study underneath it, guess what you should be doing? That case study. Does that make sense?
Yeah.
So if you're not doing that, then it's very difficult for you to actually understand, what's going on. So, just like the Filgristrum, if your white cell count is, well, we said it should be between, that neutrophil count or whatever, should be between 25, 2,300 and 6,000. If it's, 1,800, then is that Filgristrum, has it been working?
No.
Okay, so it's understanding things like that. So that way you have a better understanding of the process. So yeah, I could say only do this, only do that, but then what happens when you get to comprehensive? And then what happens when you get to HESI? So, if you do it in smaller chunks, I think you'll see better success than trying to study it all in one fell swoop.
I mean, for like most of these chemotherapies and stuff, we're worrying about the same thing. We're worried about infection, mouth sores. I mean, a lot of the interventions are the same for each cancer.
Right. And say, what if, the patient starts complaining of burning at the site? What do? And they're getting chemotherapy.
Discontinue.
You stop it. So it's, these things you actually already know. I think you guys just don't trust that you actually know things.
Yeah.
So you do know it. So instead of hitting that freak out button, it's just more of, okay, what do I know about this? What do I know about that? If you have, cancer that was in the, say it was in the breast and then it went to the lung, right?
Mm-hmm.
Then would the treatment for that be different than if it was only in the lung?
Yes.
No, it would just be a different spot, right?
Well, we all remember chemotherapy is not just for all body parts. So you don't have a one, it's not like a thrombolytic. It's going to go and bust up all clots. So you can't give one chemotherapy med and it's going to attack all cancer cells in every area of the body. So once it metastasizes, then the regimen is going to be different, because now we are trying to, it may be a combo therapy, because we are now we have cancer in two places. So if you have breast and it goes to the lung, so is this a new onset of lung cancer with different tissue type than the tissue that was in the breast? Or is it the breast tissue cancer cells are now in the lung?
First one.
Which one is it?
New set of cells.
Say that louder, please.
A new set of cancer cells in the lungs.
No. If a person has breast cancer and it metastasizes, goes through the lymph system and it goes to the lung, it is still breast cancer that's now in the lung.
Okay.
But because it's in the lung,
The treatment's different.
the treatment's different, because we can't treat it the same as we do the breast cancer because it's in another location.
Okay.
So the treatment depends on the tissue type, the staging, the cells. So you can't, it's not a one size fit most therapy. If you can walk away with that, I think you'll understand what I'm saying.
Okay, as far as chemos go, it's better just to know a few out of each class and what their side effects?
Understand the class. Understand the class of how they work. You're gonna look that drug up anyway if you happen to work in oncology, right?
Mm-hmm.
So you should, just understand, do they have a common ending, like your Your
DINs.
glucocorticoids, they end in the ONs, the
Mhm.
ONEs. Methylprednisolone, prednisone, dexametha, what?
Zone.
Zone, okay? So don't stress yourself out over that. If I'm going to be looking at something, then I'm going to be looking at, you know, how is it going to affect my electrolytes? So what's a common electrolyte imbalance? So if you look at that tumor lysis syndrome, it kind of gives you some of those electrolyte imbalances that you would have. You know, if your person has colon cancer, and usually colon cancer develops because people don't have, you know, fiber in their diet, 1. 2, they're doing a lot of processed foods. 3, they don't use the restroom every day, right? You should be actually pooing 3 times after every meal. You should be running to the bathroom 30 minutes later, doing a flush out.
Mm-hmm.
If you're going every 3, 4, 5, 6, 7 days, then that is problematic.
Mm-hmm.
So no one should be going. That's not normal for adults. The only time poo like that is normal is if you are breastfeeding a kiddo. They go every 5 to 7 days. Everything else they're eating is they're taking in and keeping.
Okay.
And so every 5 to 7 days, then they will have a bowel movement. So it's understanding that's a problem. Smoking's a problem. Obesity's a problem. GERD's a problem to set up, you know, those types of things as well. And there's other signs and signs and symptoms that can, or risk factors. That's the word I'm looking for. There's other risk factors. So now if you have a person that has colon cancer and they all of a sudden their belly starts filling up with fluid, what's that fluid called now?
Ascites?
It's ascites. Okay, so what do you know about ascites? We have now had fluid shift from the intravascular space and now it's in the stomach, right? So have you seen a patient with ascites? Anybody?
Yes, my
Okay,
mother-in-law.
oh my gosh, it looked like they're, 80 months pregnant, right?
Mm-hmm.
And I'm exaggerating on the 80 months. But my point being, the stomach is huge. So with it being huge, if you have fluid moving from the intravascular space, what types of problems would you see that person having?
Difficulty breathing.
Difficulty breathing, number 1, because you now have this big protuberant belly. It's going to be pushing up on the diaphragm. That person's going to have difficulty breathing. They're going to have difficulty walking because they're going to tire, right? So what other problem would you have?
Dehydration?
Not so much dehydration, but more think about, things that can cause a big problem in the body.
Oh, hypovolemia?
Not bulimia, but they're going to have electrolyte imbalances. So they're going to have fluid and electrolyte imbalances. I mean, they don't really get so much weight gain. It's not directly a consequence of ascites, but weight loss may result, if they have low albumin levels. So if they have decreased albumin levels in the intravascular space, then this can now decrease the oncotic pressure. And so now this is why fluid's going to move out of space. So understanding those types of things, that's why I talked about complications with prostate and testicular cancers. Don't forget about skin. Bigger. That's another one. Being out in the sun, your fair skinned folks tend more to get skin cancers. Not using sunscreen, tanning beds. So those types of things would be a portion of that, right? No, maybe. You still thinking about it?
Yes.
Oh, okay. So does that kind of help you hone in? I mean, your usual or how you should approach every exemplar is 1, what's the pathophysiology? So the book kind of gives it to you. You do have a pathophysiology book in Lippincott that you can actually look at. So I would look at that so you can get a better understanding. You should never need to go to Google for nothing. You have every resource at your fingertips, all through Lippincott. You have everything right there. Then after I look at patho, then I'm going to look at risk factors and etiology. So if you looked at how I set up that PowerPoint, literally how I've been telling folks to do it is the same way I do it, so you have an understanding of it. So now you look at patho, risk factors or etiology, signs and symptoms, your assessment, what would you assess, labs, diagnostic studies, interventions, and teaching. And then how do you know the interventions are working or not? How do you know the patient's getting better or not? What are some things you need to anticipate as problems? What are the potential complications? So that's why I had those listed in the PowerPoint, so that way when you're doing your exemplars, you should literally be doing the exact same thing. It shouldn't be anything different. And then if there's case studies, those interactive case studies, do those. You're not going to be, this is not going to be a memorization. Memorization is technically long gone. You now need to look at, what are my abnormals that I know that it's equal to this problem over here? How do I treat it? What are some things that may be a part of it? And don't forget about nutrition. You must include nutrition in on it. Does that make sense?
Mm-hmm.
Okay. Do you need to put people on, bowel regimen plans, or, especially if they have spinal cord injuries and things like that, which we didn't get a chance to cover. So do you guys find this helpful, not
Yes.
helpful, what?
I thought it
Very
was
helpful.
very helpful.
Very
So,
helpful.
I try not to address the test because from my perspective, if you are able to understand these pieces, the difference between Hodgkin's and non-Hodgkin's, the different levels of spinal cord injury and what's the concern with spinal cord injury, like the autonomic dysreflexia, like the bladder may not be emptied, it may be full, or the bowel may need to be evacuated. If I have a T injury, what problems would I see from that? If I have a cervical injury, if I have a C1 injury, would I be alive or dead? If I have a C5 injury, what complications would I experience with a C5 injury? Would it be a gas exchange issue, a nutritional issue, a functionality issue? If I have a sacral injury, what would be a common concern related to sacral injuries? So when you're looking at those pieces, you're kind of learning more, like if your patient has this, okay, we should expect these problems. So if I have a C5 injury, the diaphragm is innervated through the phrenic nerve. That phrenic nerve is located between C3 and C5. So I would anticipate that I may have some type of respiratory compromise or gas exchange issue. Does that make sense?
Yes.
So, you've had the anatomy component, but now you have to start putting those things into practice. So that's why I said it's more that you need to know more than just, this plus this plus this. You have to start thinking about, I noticed this, what does it mean? So this is going on, what does it mean? And that's why sometimes I ask you, what does this mean? Why do we need to know this? Why are we concerned? Does that make, so that way you can start thinking about, why do the person has this and why is this important?
So Ms. Hudson, in regards to the prostate cancer, I did find in the book that some of the genetic mutations were the HPP1 and sometimes the BRCA1 or 2 in men. Would you confirm that, or is there not, other than the PSA and the DRE, other than that, are there any specific genetic mutations that you would see in prostate cancer?
You mean for the guys?
Yes.
Okay, yeah, there are other mutations. I'm gonna go back to let me go back to this slide. I didn't show it on. It was a slide that I showed my students, and I'm trying to see if I put it in here. What I did. I'm looking first before I say yay or nay. Actually, I have a slide, but what I did is I just put the name. So so tumor markers. So like for breast cancer, there's additional tumor markers like CA 15-3 and then CA 27 through 29 or -29. So there are other cancer markers. However, you know, that's pretty specific, and that was really a protein marker. There's because you have antigen markers, you have hormone markers, you have protein markers, and then you have enzyme markers. So the alpha fetoprotein, which I talked about before, looks at the gonadal germ cells, and we talked about that in testicular, right?
Mhm.
Alpha fetoprotein.
Yes.
But that's an antigen tumor marker. And so then the HCG, that's a hormonal marker, but that's for testicular.
Okay.
Okay. And then protein would be like your PSA. That's for your prostate.
Mm-hmm.
And then you have the CA 15-3 27-29. That's going to be your breast. But then for colon cancer, then it's CA 19-9. So there's specific ones. In your book, it talks about the HER1, so the human epithelial growth factor receptors.
Mm-hmm.
And you have a receptor 1 and a receptor 2. And so that's also for breast.
Okay.
Okay. So it's besides the BRCA. BRCA only hits a small portion.
Mm-hmm.
I want you to understand that it's more than just BRCA 1 and 2.
Right.
But it's also HER 1 and 2.
Okay.
Does that make sense? And then they can get more specific with some of these other markers, but they're finding, as they find more issues or more, folks are developing these cancers, then they're looking at more markers for that.
Okay.
Okay.
Mm-hmm.
So I kind of hope that helps you navigate, but I don't want you to drown in minutia.
Okay.
Does that make sense?
Yes.
So don't drown yourself in minutia. Unless you work on an oncology floor.
This is pretty broad. Right.
That's going to make a lot more sense. But look at your more common labs associated with that condition. It doesn't mean that there are not others. It just means that, we have some common ones, and then we have some that we know give us some results. And speaking about breast, it's even the same thing with the self-breast examination. You can do circular motion as you're doing the breast exam, but you should go in a vertical pattern. Does that make sense?
Mm-hmm.
So you should go from the top of the breast to the bottom, and then go from the bottom back up to the top, but move over, and then move over again, go down, but you're still doing the circular motion, but you're going down the breast, then back up, then back down, then back up to get the best coverage of that particular breast, of that breast, to check for lumps or anything. Okay. So do you think you'll need another Zoom session next week, or you think you're good?
Perhaps, yes.
I like Zoom sessions.
Yeah, I think they're very helpful.
Okay.
If you're willing, I'm here. So
Okay. I don't have a problem doing them. So It's really, I try to do them when it's convenient. I will send out the, it'll be, your YouTube channel will be DCCCD S1. So that'll be your YouTube channel. And then once this uploads, it'll be there. And so you can look at it, listen to it, you know, do whatever you feel you need to do.
Cool.
Very
All
nice.
right. All right. Well, we have 5 minutes, so we can either stay on or sign off.
I think I'm okay. I mean, I'm not okay, but I feel better.
Okay. So yes, you do the raising the bars. If you're not doing those, you need to start.
Hmm.
And then on spring break, I would kind of catch up, you know, so that way you have it ready for your comprehensive.
Okay.
So if, you know, if you haven't been told about the raising the bars, then you need to do those. But you have to start, you know, studying in smaller chunks. That smaller chunks, it works.
So I hate to ask if that's going to be on the test, but we were talking about leukemias in class with Miss Smith at Northlake, and she mentioned the leukemias and the lymphomas. I know that you had talked about multiple myelomas, but she didn't mention it. So, and it wasn't on her PowerPoint, so I just wanted to verify that, you know, that would be some knowledge.
Let me look at the,
It wasn't in our readings on Lip Caught, but I wasn't sure.
If it's in your readings, it's in your
it
exam.
should be the lymphomas. Hold on. I'm going to quickly pull up the not cell reg. Yeah, it was cell reg. And I can tell you real quick. All right, so for cellular reg, what you had to know is, chime in. I'm like, is this my phone chiming? It's loading. All right, so it says it's very vague, so that no helps.
Yeah, a little.
Like that is no help. So let me just actually find what I went to the first time, and then I closed out of it. Let me just find the actual course syllabus for that, for cell regulation, and that'll make it a lot easier. Because it just says lymph proliferative, so I don't need to study anything else that you don't need to know.
Yeah, and I know that multiple myeloma is technically a lymphatic system issue, but I just don't know if that falls underneath it or not.
So when you go to the research, when you go to your syllabus, your course syllabus, it does say lymphoproliferative, but as you scroll through, it'll start listing out certain things like breast cancer, colorectal cancer, leukemia, then graft versus the tumor effect.
This is on community.
Hodgkin's and non-Hodgkin's. So those are the ones that prostate and skin. So no, you don't have to do multiple myeloma, just have to know Hodgkin's and non-Hodgkin's.
All right, cool. Very nice.
There we go. All right. Sounds good, guys and girls and ladies. And
Thank you so much.
Try to you know, hone down your overload, so that way you're not panicking. Okay. And then when will work best for you guys? Because you have lecture next week. It'll be your last lecture before you take the test on Monday. So would Friday work best for you guys? Would that be a better time? Someone says Saturday, not next Friday, Saturday.
Yeah, we're in clinical on Friday. Some of us are.
Okay. What about Thursdays?
I could do Thursday.
Saturday's better. How many folks could show on a Saturday? Because I have some Thursdays and then I have some Saturdays. And if you can't do Thursday, you can always listen to it. I would rather do it earlier, personally. And if I did it Thursday, it would be Thursday evening, more like 6:30 to 8:30. If I did it Friday, then, my time is a little bit more open. So we can do Thursday, we'll do Thursday 6:30 to 8:30. If you're on, okay, cool. If you can't, no worries. It wouldn't be Thursday during the day because I'm busy during the day. So I'll do it from 6:30 to 8:30, and I'll send out the same. It won't be the same link, but you'll get a link just like the one you received.
Cool.
All right.
Yes.
All right. Try to enjoy your weekend. It's going to be almost 80 degrees.
Yay. Thank you so much.
Thank you,
You're
Miss
welcome.
Hudson, for letting the Bridgers come.
No problem. Anytime.
We miss you.
We miss you too. So we'll catch up. We'll talk. Bye.
Bye.